AHA session on cracking the code, how data science and AI at the bedside is changing patient care. I'm an associate director at the Kaiser Permanente Northern California Division of Research, overseeing its cardiovascular, kidney, and metabolic health research section. I'm here to give a quick sort of set the stage, and we'll tell you that, we all know the AHA has long been the leader in advancing cardiovascular science, improving healthcare quality and outcomes, and it's exciting to see the strong emphasis that the AHA is placing on data science and AI across multiple sessions at this meeting. And we've all witnessed, and you're here today, about how data science and AI are really transforming care, going from concepts to pilots to now soon becoming integral to the way we provide high quality and efficient care. So in today's session, we're going to focus on what happens when these innovations try to move from theory to practice to the real bedside where we can meaningfully change and improve patient care. Now, I work at Kaiser Permanente Northern California, which people may know is one of the nation's largest integrated healthcare delivery systems. It also includes the Permanente Medical Group of 10,000 physicians. And I'd like to share just very briefly a perspective to set the stage. And at scale within Kaiser Permanente, we care for 4.5 million members in Northern California alone. And we've seen how trusted evidence combined with effective decision support tools can empower physicians and improve quality and patient outcomes. And they're most impactful when they're seamlessly embedded within EHR systems and clinical workflows. So just two examples, starting with when we encounter patients that we've now actually deployed fully within our system an ambient AI scribe tool that allows our physicians to focus on patients more during those encounters, capture the engagement more fully, and help them execute both their notes and care plans. Another example is an upcoming implementation of the AHA Prevent Risk calculators throughout our system. Now, we actually independently validated the clinical utility and accuracy of the Prevent equations in Kaiser Permanente in Northern California and more than 2 million primary prevention patients. And that combined with our collaboration with the AHA through their licensing agreement is going to allow us to soon implement those calculators at scale in our various screening and care pathways using automatically calculated scores. And that reflects our shared commitment between our organizations to use validated evidence-based tools to personalize risk assessment and prevention strategies. So as we look ahead, the promise of data science and AI is clearly enormous, but not without its challenges, and hopefully several of these issues will come up, including issues of ensuring clinician trust, reliability of the tools, data quality and completeness, equity, transparency, and cost, as these will continue to shape the future of our field. And our presenters and discussants today will explore, I'm sure, many of these opportunities and hurdles as we can ultimately see the full promise and potential of these technologies to improve patient care and outcomes. So thank you again all for joining us here today, and I'd like to turn it over to our moderators and look forward to our discussion. Thank you.
Oh, they're actually on. There's no light. This is great. Thank you very much. I'm so grateful to be joined by this wonderful panel to discuss what medicine is and what medicine is becoming. I looked at the schedule for AHA and I filtered it for AI and bioinformatics, and there was a session at almost every time slot. And it has really changed on what is happening. And I'd love to hear from the panel what you think is the new phenotype of the cardiologist that's going to be ready for this world that we're entering in. Or
okay.
clinician in general.
Okay, that leaves me and you. Okay. Okay, let me step back for 1 second. So I'm Rashmee, I'm a cardiologist. I have an adjunct appointment at the University of Utah, but I also work for Meta. So I build digital health algorithms with a team of engineers. It's fantastic, but I live in a bubble, the metaverse. So in my view, this technology is going to change the world, but I live in this bubble. So what I'd love to know from the audience, what do people think this technology, like just a quick yes, no, is going to change how we do all this work? Is substantial change, or is there a lot of skepticism? Okay, so actually not a resounding yes. So my sister's a cardiologist at Harbor UCLA, and she also does not think this technology is going to change the world. So I think for cardiologists, there really is a split, like what is the phenotype? There's some group of people who, like, no, what is this? This doesn't make any sense. And there's people like me who's like, oh yeah, this is definitely going to change things in how we deliver care. What it I think it means, so I wrote an editorial for one of the Nature journals a couple of years ago, and there's sort of at least two skill sets that will really become really important for delivering care. One is statistics, because the models are statistical models, and the thing you need to understand is the pretest probability of the thing it's trying to detect in order to use it well. So I think statistics is going to become very important, increasingly important if it's not already. And the other is understanding how humans make decisions. So I think like the last session was a really great example. I think AJ mentioned that, yeah, the patients are going to come to you with the AI answer and ask you to, is this right, is this wrong? And you need, the skill is how do humans who are highly unpredictable, how do they make decisions given a certain set of information, which may or may not be like strictly rational decision making. But I think those two skills are going to become increasingly important in the next era.
So actually, I'm happy to provide a perspective as a general internist, actually, but who spends most of my life doing research, which I think that, I take a health system perspective, which is that, having physicians that are able to be facile with the technology while also being incredibly good with patients, which we all think we know of good doctors. And so it's having the technical capacity to leverage the tools. They're not replacing the physician, but they can make it more efficient and more effective. And to replace some of the, what I consider lower level tasks and really focus on the complex thinking because it's not really truly intelligence, it's artificial, and they're tools. And so it's a way for us to, I think, maybe paradoxically connect better with our patients, actually, and have that capability.
I think I'm a primary care internist and spent all my life practicing with patients. And I think the thing I've seen with AI and where it can be helpful is definitely the early adoption of the scribe service. I talk with some of my colleagues, and it's saving them 2 hours a day because docs are crossing, the T's and dotting the I's and not having time for the patient. I think that if we do this right, that burnout at least among primary care physicians, can be decreased. And there are some early studies from Kaiser, et cetera, that show that is the case, because that after-hour time, when you go home, when you should be recharging, dealing with family, enjoying, you don't have the opportunity to do. I think where the issues come in are numberfold, and one of them is that lots of times your physicians who are very experienced, very good, and know what they're doing and do it quickly are not going to want to adopt some of the new things because it takes time to learn it. And I'd rather focus on doing my work than taking the time to learn this new thing. My daughter is a director at Amazon, and she said one of the issues is that you have to have your most efficient, most experienced providers using these tools and giving the feedback so that they learn and they get and the tools get better. And that sometimes is what is lost because they say I'll just keep doing what I'm doing until I'm forced into doing it a different way. So I think there are a lot of I was interested in the Stump the Doctor session. The ones, at least when I came in, they'd done the echoes and the electrocardiograms, and AI won, although the doc said, I'd rather see some more views, which is how we would actually make those decisions. But when it got to the patients and the scenarios with the patients, that's where the docs were right more of the time, because it is that human factor and that seeing the patient and looking at them that AI is not able to do, although my daughter said, Mom, the thing to say is that it is no longer what can AI do for humans, it's what humans can do that AI can't. But then she added yet at the end of it, which really made me nervous.
I thank you. That's really insightful. Dr. Hall, I'd love to ask what is the AHA doing in terms of enabling this AI feature in a responsible way?
So the AHA just launched an AI assessment lab, and the booth is right over there to the right if you want to get some more information about that. But we feel that there was some disparity and unequalness because some of the larger academic centers had the capacity, they had the data, and they had the faculty and the resources to be able to adapt AI, and some of the smaller rural or community hospitals did not have that. So true to our mission about being a relentless force for all, we felt that we could fill a space here to provide testing of algorithms from an unbiased third party, which would be the AHA, that would help an AI developer be able to talk to a CEO or a final decision maker at that hospital to say, you know, this algorithm that's going to predict HCM, for example, has been tested by an unbiased third party, and it's showing rigor in addition to whatever is beyond the FDA assessment, which is not always a high bar. It's a bar, but the AHA has a much higher bar for people that we want them to meet.
Thank you so much. I'd love to hear from the panel, as we build these AI and technology solutions, there still seems to be a last mile problem of getting those solutions to the bedside. And if you look at what happened during COVID, I think is a prime example. Now the review literature is coming out. They said there were about 60 models created to determine COVID from chest x-rays. Not a single one of them was deemed implementable. Not that it didn't get implemented, but it was designed in such a way that it was not implementable for clinical care. How do we solve this problem?
Yeah, I'm happy to start. I think you're absolutely right. It's really challenging because we were in a session yesterday just for around AI ECG algorithms, of which there are now multiple depending on what you're trying to find or predict. And I do think that there needs to be a broader collaboration from, for example, EHR systems groups, in addition to the academic groups that are developing and the technicians. And I think, as MaryAnn said, we need the physicians also involved from the front line to know how we're going to actually use that. So what I mean by that is I think that we often forget things that need to be done at scale. So again, where I work, we're trying to do this for millions of patients, for complex systems, and any one tweak in that system, like trying to put in a model that doesn't actually work within the EHR, that you have to put around an EHR, adds levels of complexity and cost. And also, as I alluded to in my comments, is that it's clinician trust and patient trust in the results. So if it was done in one place and tested, is it going to be accurate in another place? And then once you get through all that, now can you implement? By then, 20 more models have come out. So I do think that we face an arms race in terms of AI development of any kind of algorithm, and increasingly across diagnostic tests, leveraging EHR data, taking all the encounter data that's coming when we interact with patients. So I think it's solvable, but I think that we, as we develop things from the beginning, we need to think more about the end game from the beginning.
Yeah, I think that another way to phrase that is like it's user-centered design, and people, for example, Epic was not exactly user-centered design. People say that a lot, and the other piece is you have to solve a problem for the user, a problem they want to be solved. So like the ambient dictation solutions, that solved a real problem for the user, and the adoption wasn't an issue. They had a user-centered design. It was a real problem. They were laser focused on solving that problem, so it worked. So I think the user-centered part, it's like if you show a hammer and nail, people have data, computer, they're going to build a model, but really what problem are they solving?
I also think when you talk about the inability to implement, these kind of issues are not something new. When we look at the drugs that come out, right? When we look at nicotine patches, when they first came out, suddenly people were having blood pressure drops and heart issues because in the studies, nobody smoked when they had a patch on. But as soon as it got to the general public, people said, oh, yeah, I'm going to put a patch on and I'll smoke less, and they light up a cigarette and they have issues. Same thing happened with Prozac. Same thing happened with Viagra. All kinds. We didn't have any warnings about nitrates and Viagra, so people's blood pressure dropped. So these are issues that we've faced before. Unfortunately, with AI, as Ellen mentioned, it's going so fast that when I was looking, I did what I usually do when I'm going to give a talk, which is do a literature search. I usually go at least 5 years back and then talk to people and then kind of formulate ideas. But when I went to 2020 for something about primary care and AI, all they were scoping studies. There was nothing there. So everything was 24 and 25 before you could find anything. And so I think it's happening so quickly, and by the time I read those studies, they're on to the next version. So I think it's going to be a continuing issue. It's not new, but it's going to be much larger and quicker because of the arms race for it.
The only thing I would add is carrying on to what MaryAnn said, is that if you go back 5 or 6 years and you think about the publications that were coming out, it was heart failure predicting with 27 or 37 variables, right? And we published that and we thought that was awesome. But we weren't thinking about deployment. And so it really is going to take the best data science with the best implementation science and sort of developing a new field as we go along to understand, how are we going to do these things at scale, and then rigorously test them once they are in place to be sure that patient care is actually improving.
May I ask a follow-up question about that? Jennifer, that is a really great point. How do you think guidelines have to adapt to promote that?
Great question. I think as the American Heart Association and the ACC write the guidelines together on many things, that there's always different classes of evidence to support different drug treatments. And I feel that this space of AI and prediction algorithms is going to fall in that same sort of space. That is it type 1A evidence, line of evidence, that this algorithm really improves patient care. And I think that will help us sort it out. But at this given time, there's not a lot. They may have FDA approval, but they don't have a lot of prospective randomized clinical trials to support.
I want to piggyback on that question for the panel, for me. So when I think about guidelines today, a couple of years ago I said, gosh, those guidelines need to be computer readable, right? Like a human reading it is sort of irrelevant now. It has to be computer readable. And the other thing I wonder about is we have this concept of class 3, causes harm, but is there the guidelines now need to start to take a role to define the guardrails for a model. So if you have an AI developer engineer, they study something, they use open evidence or whatever, but they're not a domain expert. So they don't actually know the guardrails for the thing they are building. And maybe that is an important role for societies like this, is to, what are those guardrails that, especially when something goes live in production, you should be constantly monitoring, did it pass your guardrail? Somebody has to define what that is.
And my suggestion from the primary care standpoint is they need to be shorter. Because for primary care, yes, we have the algorithms for hypertension, for congestive heart failure, for all the cardiology, but we also have all the pulmonary, all the GI, all the rheumatology, all the musculoskeletal, all the depression, all the reproductive, and everybody has best practice on everything. And it is really hard. I think that's a place where AI can help.
No, I'll push back on that. I think they need to be longer, because humans are never going to read them anymore.
Well, that's
You need
true.
something to train the model on. So make them long, make them detailed, make them specific, because the human expertise is going to become more and more important. So what's happening? There's like foundation models, big labs build those. There's a fine-tune model, and there's the app layer. That fine-tuning piece requires domain expertise. So write a really long, in-depth, detailed guideline for the computer.
And then how does it get to us? That's the question.
Then summarization of text is really, really well done with LLMs, right? So, but you can't not write less. Domain experts cannot write less, right? That's important, I think.
My big frustration, since my undergrad's in computer science, I'm totally a process guy, is that we still live in this era where guidelines come with infographics and not standardized process diagrams. That is a disservice to everybody that's out there. It's like making up math symbols and saying, look how wonderful we did on this math equation, when it's not really math. We do the same thing. The fact that we don't have UML standard process diagrams and guidelines is mind-boggling to me. The other part of it is where AI really struggles is we tend to put, A1C in models, like Prevent is a prime example, right? It has A1C in there. But it's very different to say someone has an A1C of 7.5 when it's their first diagnosis and their first ever A1C, different from somebody who has a 10-year history of A1Cs of 12 and now they've achieved a 7.5. And we don't do an effective job with that. I think our smoking colleagues do an amazing job because of this concept of pack years, which gives you this integration of their overall risk over their lifetime. We don't do this with other chronic diseases, and the guidelines have to make that easier for the, the AI writers to be able to say, how do I put this disease into context that I can then put into the model and make that model more effective?
Yeah, I'd actually build on that further because you mentioned about integration. And I think that one of the challenges we have is that there's so many professional societies with different guidelines for different risk factors, and yet we're facing one patient in front of us. And so how do we integrate and have a holistic view so that we can actually carry that out and still meet all of our quality metrics while also treating the entire patient in the most efficient way possible and do that which provides the best personalized net clinical benefit. I think that's the challenge, actually, where I'm hoping that AI will help with that as we begin to take those components, integrate them in, and instead of having to read a 120-page guideline and 4 times 4, to be able to get to the one patient to make a prioritized set of decisions for them in that 15-minute encounter. I think that's the challenge.
One of the biggest challenges with guideline implementation has been copyright and licensure. Who do you think owns these guidelines, and who needs to approve their implementation and monetization in digital solutions?
That is a loaded question that I don't think I should answer. Let's go on to the next, and we can do a round table on that one.
That is totally fair. When we collaborate with colleagues, what skills do you look for when you look for that collaboration? And I see a lot of young learners in the audience here and young physician scientists. If you could step back a couple of years when you were also a young scientist, what skills would you wish you would have known sooner?
Well, I was trained by Dr. Go for some of my research careers. I would do exactly what he did. I am a huge fan of statistics. I just think medicine is statistics. You look at somebody, there's a pre-test probability of something, you collect some set of data, and you come up with the post-test probability. That is medicine. And if you take that to maybe now next stage, so I program in Python, and I go back and forth, like, should physicians, somebody coming earlier in their career up in the field, should they learn that? And before I used to say no, but now because of AI, I actually think you should. Because if you know just enough, you can use all the agents to build your own prototypes. And that will do 2 very important things. One, it will help you work with your engineering colleagues because you'll be able to get closer to speaking in the same language to build stuff. And 2, you will be a physician builder. And we need more physician builders because they fundamentally understand the problems we're trying to solve. And I think, like, I like Atul Gawande's books, and he wrote a book called Better where he says you should count something. I think that should be revised now to say you should build something. If you haven't used the agents, like Figma's AI agent is fantastic. You can make a UI in like 2 prompts to like demonstrate the thing you want the engineer to build. And I think if you want to be in this space, use them, try them. It's going to take you far.
I think from the primary care standpoint as well, I think that there's a lot of grunt work that you do in all practices and with patients, but there's a lot of all of the administrative details, the quality measures, the insurance measures, what codes you need in order to do a level 3 versus a level 4 because you're paid on those kind of things as well. But I think sometimes what is lost in doing all of that is that connection with a person. I mean, people will tell you stuff that they will tell nobody else, right? They'll share things in their life that they're most afraid of. And I think building those trusting relationships is really what makes primary care fun and interesting and worthwhile. And I think very often, and what I see among young clinicians now, because it's become more of an 8 to 5, you no longer take care of your patients in the hospital, which was when you're, it's always been weird to me that when your patient is the sickest has a real problem, the person who knows them the best is not involved in their care. And so you need to do that trust and have that trust in order to really feel that you're doing something for these patients. And I think primary care docs need to recognize that and to use all of the tools that are there to take care of those things that are the grunt work as much as possible, so that they can focus on not only the patient as a problem and what they have, but as a holistic person, and where they can help. Because sometimes it's not the diagnosis that the patient most remembers. It's how you talked with them and how you met with them and how you got them into the office when they needed you, and that kind of a thing. So I think there's a real humanistic approach that we can use and use these tools to help us with that humanistic approach.
I think those are terrific comments, so let me try to add just a complementary perspective, which is, I get back to the end game, and MaryAnn got at that, which is what are the problems we're trying to solve? And I think if we start there, and then we identify the tools, if they exist, then I think it's a blend of having team members that can understand how to do that. As you suggested, process measures are huge. Process is very important. They vary by setting, by practice, by specialty. And the ability to have, to be nimble in that way, to work with both the technical experts, being a domain expert, as Rashmee alluded to, always remembering the patient and having a perspective on solving the end game first. I think we'll get people who are young and in this field will be, I think, the most successful, the most impactful, I think, to both the groups that I practice in and health systems, as well as for our individual patients.
I don't need to glom on. I think you got a lot of good advice there.
Yeah. I would just add one point is, don't be satisfied with the status quo. If there is something that is making your life difficult, figure out what your institution's ability to make changes and work through those frameworks to make that change. Because it'll not just benefit you, but probably the entire population. And we tend not to do that, either because we think it's not possible or we think it's too difficult. I'd like to bring up a topic around this on AI. David Bass just wrote a letter, I believe like a week ago, along with his colleagues, advocating that there needs to be a new subspecialty in medicine tailored towards AI. Do you think that's the right approach? That we need, like, instead of just cardiology, we have a subspecialization in cardiology /AI. Is that where we're headed?
No, no way. The training is already way too long. And I mean, geez, we have to move faster, not slower. So I think, I don't know. I think you just learn, you learn some basic skills and then just build, just do it. See the problem you're trying to solve. Because everybody here already has so much expertise, right? It's not like you're an undergrad. You already have a lot of expertise. So just, I don't think we need to add more training. I think that training is way too long.
I think actually the whole point of AI is really to democratize things as opposed to sub-specialize them further. I think that it's a tool, and I think that's important. I think from a training perspective that there can be additional opportunities, but I don't think that we need another subspecialty to do that. Because then I think it suggests to me that we could actually inadvertently create more disparities rather than less, which I think we hope that AI and the tools and the data science tools will actually reduce those disparities rather than, again, inadvertently making it worse. So I hope that we all take advantage of the AI tools and the data science tools rather than the opposite.
Yeah, I think the thing that we need is training in AI during our training programs. So how do you validate? How do you find bias? How do you see that? Where do you go to check to see if the AI tool was correct, whatever you were using? That's where I think clinicians and young clinicians really, and seasoned clinicians really need the training.
I would agree with Alan that it's going to increase inequity. This is my crystal ball, and then it would increase the cost of care, as well as create some workforce issues probably if your hospital didn't have that, or how you were going to then communicate with that person. So maybe there's some positives, but I think at this juncture I see a few more negatives.
So I get to teach a 1-hour class to the medical students on AI. And it's normally taught by PhD data scientists, and they got poor reviews, and they said, you need to get an MD in there to tell them why they need to know this. And after that class, about half the students always stay. And they ask me, what residency should I pick so that AI doesn't take my job? And I'd love your input on what advice to give them, other than just becoming a proceduralist.
That was my answer. Become a surgeon.
Oh, wow. Okay. That's a great question. I think, my daughter is also in computer science, and, I asked her, are you going to be replaced by an AI tool soon? And I think what she said to me was very insightful, which is the people that are going to win are the people that can leverage these tools the best. Because human creativity and empathy, as my colleagues here have mentioned, are still going to be incredibly important traits. So I think it's actually is about being as informed as one can, being an early adopter, and yet having a really critical lens, which I think both MaryAnn and Rashmee and Jennifer have been alluding to, that are going to make someone successful regardless of their field. Even in radiology, which there's a lot of fear that a computer vision tool will replace them, I still believe that at the end of the day, there's going to need to be humans involved to help with interpretation, but they should leverage tools that allow us to look at these images in a more accurate way so that we can do the best by the patient, but we still need to treat the patient. And that's why I think that across all specialties, I hope it just pushes up the, working at the top of our ability versus the other way around, which is replacing us.
And I think that the things that AI can't do, and I do preface with your yet, but can't look at a patient and see they're scared, can't touch the patient and offer comfort that way, can't tell a patient a diagnosis of cancer or whatever, and say, but we're going to get through this, I'll help you with it, because it's just going to say, yes, you have cancer, or no, you don't. And so I think there are all those aspects of it, not only the judgment, not only being able to see bias, but also that human touch with people that, the ones that, as I said, that physicians did the best with against AI was when it was not just reading an electrocardiogram or an echocardiogram. It was, we've got this patient who's got all these different things going on, and do we tell her she can get pregnant, or do we tell her she couldn't? Should she need a procedure? Should she not? And that's where I think physician and human physicians have the skills that AI does not have yet.
I heard a quote a week or so ago that said, you can't wring your hands and roll up your sleeves at the same time. And I think that applies here, because there's a lot of worry and angst, but like Rashmee's been saying, you just need to step in there and do it, and also see the opportunity that it brings your students. But I think there is so much fear that it tends to even cloud their ability to think how their career could be enhanced by the use of AI in the clinic.
And we should never have watched 2001: A Space Odyssey.
Well, the one thing we talked about last night is, for training in this era, I actually kind of have this thought that deep expertise and true expertise is going to become really, really important. Because, there's going to be builders, there's going to be people who are in that world, but there's people who need to write those really, really long documents because they deeply, fundamentally understand that topic. So if I went back to training, working with trainees again, I would train them by not using AI at all. I would have a piece of paper with the article, and a human sit there and read that and really think about it and develop those critical thinking skills. Because if you think models are already 80% there, that last 20% is all edge cases and outliers, and you need really deep understanding of the domain to handle those. So if I'm going back to training someday, it's going to be around a table with a pen and paper and really human thinking about the content, because I know that's what's needed for the last 20% here.
I think that's so critical to cardiology. As subspecialists, we primarily see that 20%, right? It's already been through a couple of providers already before it gets to us, and they're asking us for that deep expertise. So to build upon this, where would you recommend people start to learn some of these skills to be better involved in AI?
say the last part,
better involved in AI? What educational resources or what abilities do people have to be able to do that?
I mean, I think it's build something, right? There's lots of free courses now. Like, I think Stanford just put out their whole AI curriculum online. Anybody can watch it.
edX.
Yeah.
It's under edX.
Oh, edX. Okay,
edX.
yeah.
EDX.
And I'll do a plug for my friend Graham Walker. He's actually a Kaiser ER doc. He has a bunch of videos on off-call to get you started. But just try. Just like, once you get that little, this is what I realized when I was a postdoc with you, Alan. Like, once you know a little bit and you start to see what you can do by actually just getting in there and doing it, it opens up a lot of doors. It's just that little hurdle. Just pass that little hurdle and try to build something.
I agree, and I think, again, I'll come back to finding a problem that you care about solving, within your own practice, within your own system, because once you do, it really does open you up to all the different things that you do need to learn, and that gets you to a wealth of free resources that you can learn, and then opportunities to also learn how to partner more effectively, which AI cannot do for you in terms of building and working within teams, because it's a team science for medicine, and in cardiology in particular. And so I think that's an opportunity, to grow as a physician and care leader as well.
Well, it's a little too obvious for me to say, come to the AHA scientific sessions and learn more about AI. But as Mujeeb was saying at the beginning, there's a lot of sessions here, and I would encourage you to talk and communicate to people that you might not have before, but if you learn what their system is doing or what troubles they're having, I think you'll meet a lot of new friends and also learn very, very quickly, more quickly perhaps than you would if you were taking a class, which I also encourage.
It's really remarkable. I interact through my job at CMIO with a lot of PhD researchers, and the complaint they always have is we can't find enough clinicians to work with. So if you just put your name out there and says, I'm interested in this and want to collaborate, you'll be amazed at how many people come out. Now, it's going to be volunteer time, so you're going to spend your own time doing it. But if that's an area you want to grow, that is a great way to gain experience. Every company that I've looked at has some type of clinical advisory board if they're involved in the clinical domain. That's also a great way to get involved and learn about what's coming out next. So if that's an area that you're interested in, there are a lot of societies, and I think what AHA is doing is quite remarkable. We're almost out of time. Is there anything else you guys would like to add?
Come talk to me if you're a clinician and you want to partner with a data scientist, because I have a lot of them that would be really happy to talk to you, and I'd be really happy to get your names and follow up with you.
Wonderful. It has been an honor to be on this wonderful panel. We're going to stop the panel sessions and we're going to break out to the small tables on the side. If you guys would like to continue this conversation or ask any further questions, please join us and we'll be happy to continue this conversation. Thank you so much for coming. It was a pleasure.